questions. So please take.
Yeah, thank you, Neha.
Thank you, sir.
Before we can go for the discussion on hypernatremic dehydration, I think we can first have the visual spotter. Neha, can you please share the slide?
Yes, sir.
Yeah, thank you. Next slide, please. Yeah. Well, can any of you tell me what this ultrasound image is showing? Well, to help, this is not related to hypernatremic dehydration. This is an antenatal ultrasound picture. So anyone can tell what is it?
So is it choroid plexus cyst?
No. Anyone else? All right. So basically, it is showing a triplet, 3 gestation sacs. I'm sorry. Yeah. So these are the 3 gestation sacs representing triplet pregnancy. One sac is which you can see in the upper image, in which we are measuring the CRL length to see the gestation of the baby. This is the second sac, which is below it. Again, we can see some fetal pole, though we cannot measure CRL because it's not showing proper picture. And the third sac is on the left of the sac, which is showing the third fetal pole. Again, we can measure the CRL, but again, it is not showing the proper image from where we can measure the CRL. So basically, I have tried to get this image for the today's visual spotter just to highlight that, just to sensitize that we should be aware of the diagnostics during the antenatal ultrasound, antenatal period, and we should have some information about that. Thank you. Over to Akanksha, Dr. Akanksha and Dr. Saikat.
Thank you, Dr. Chinmay. And I think very well presented. Both the resident Neha well done, and Dr. Shell, he did an excellent job taking us through all the approaches we can have for the babies hypernatremia. But we've almost gone through all different types of calculations that are available. But I think the most like easier one or what is practicable bedside is either using the apps or as the approach has been shown by the Dr. from HIMS, that taking around 1.5 to 1.5 times of maintenance fluid, that will, and replacing it with N by 2 or N by 2 depending on the severity of hypernatremia. It takes, and in practical scenarios also we've seen it most of the time it takes care of the correction of hypernatremia. We just need to keep a watch that we do not overcorrect or we do not correct it rapidly, especially if it is a case of chronic hypernatremia, because we do not know how long that hypernatremia had been there. If it is performed more rapidly, then the abrupt fall of the extracellular toxicity can actually lead to the movement of water or can lead to cerebral edema, which potentially deleterious consequence. So we should all be aware of it. And apart from it, it's important to know it is not always IV fluids that are required to correct these. Mostly it is because of the inadequate breastfeeding. So increasing the frequency of breastfeeding or spending some time with mother helping her more frequently feed the baby can be helpful. So I think if there are, Dr. Saikat, if you have any comments or if there are any residents who want to add on, or if anyone, they're welcome to do so.
I think excellent presentation by both the speakers today. The point which needs to be highlighted, and we have tried to highlight through Dr. Shailendra's slides, is that one size does not fit all. So there are multiple formulas, and what will hold good for one baby may not hold good for another baby. So we need to be bedside, customized, individualized for that patient. If one thing is not working, we need to go back after 4 to 6 hours, check the serum sodium, check the osmolarity, and need to modify our plan accordingly. So that is one thing which we wanted to highlight through our case. I think rest of the points were well discussed by both the speakers.
Good morning, and I want that all fellows should make some remark or ask questions. Should not be passive sitters here before faculties make remarks.
I have one question from Dr. Neha. Dr. Neha, I want to know, do you have any clinical experience of using this formula that you have taught us today very nicely? Especially because as we have discussed this formula, so like you have told that solute-free deficit we are giving in first initial calculation, we are totally giving that solute-free deficit. So the amount of total fluid that we are giving to our baby is actually more on day one, and then and day two it's quite less. So can you please share your experience of managing hypernatremia with this formula or with this calculation?
Thank you, Dr. Karuna. Yes, we had one baby who was on breastfeeding plus formula feed in our neonatal ward, but inadequate dilution and inadequate feeding led to hypernatremia in this baby with severe hypernatremia. So in first 24 hours, when we did not wanted to overcorrect it, we had calculated using this formula. The amount of fluid, yes, it is more in first 24 hours because the amount of solute deficit is also being added and amount of sodium deficit is also being added. So this correction from 180 sodium, this was corrected over next 48 hours. But yes, in one baby we have corrected it. Yes, but not in giving hypertonic saline added to sodium IV fluid in boluses deflowation phase. We have not done. But in one baby we have calculated this with this calculator.
Okay, okay.
But it is not fitting to all the baby sets as I mentioned. Every baby is different, may require.
Actually, then we came to this conclusion that if we are just giving 1.5 to 2 times of the maintenance with the sodium deficit calculation, will also help us in correcting this. But
Yes,
as Sekar sir has also rightly said that one formula is applicable to one baby, may not be applicable to other baby. So that's how we can, like, I think came to this conclusion. Thank you, Dr. Neha. Thank you.
Thank you so much.
DM exam going fellows? No remarks?
Yes.
Yeah, please go ahead. Go ahead. Yeah.
No.
Abhijit Harkiran.
So, hello, sir. What we have seen. Good morning, sir. What we have seen in our practices is that working with the formula, it does not go well in the initial stages. It works well, but then intensive monitoring has to be done, and we have to revise. We may have to revise the fluids again and again.
Okay, Harkiran.
Yes, sir. Good morning, everyone. Yes, sir. As sir mentioned that all we have to customize and individualize. It may not apply to all the babies, right? As has been emphasized that initially, like the formulas and given in books like Harriet Lane, initially for the initial period, like the restoration of volume, it does not always apply. And besides that, urine output monitoring, dehydration status, and sodium patient counseling, parent counseling, all that is also important.
Any other fellow would like to make a remark?
Hello, good morning, sir. This is Gaurav Gautam, sir, from SGPGI, sir. Sir, I want to remark. Sir, in my limited experience, we have noticed that there are various formulas given for the correction of sodium, and none of those formulas fit to correct the sodium, sir. Mr. Nelson says that in case of hyponatremia we can give 150% maintenance along with N/2 hypernatremia ke liye, sir. So what is the evidence behind that that line, and what is the rationale behind that line, sir?
So नेहा से पूछ रहे हो? नेहा रिस्पॉन्ड करो, सब्जेक्ट मैटर है।
Thank you, Prakash. The basic reason for using N by 2 dextrose is that when we have moderate hypernatremia, the N by 2 concentration sodium is 77. It is being seen that in one of the cases, also in one of my slides, I've mentioned that the isotonicity and amount of free water which is there in N by 2 saline along with dextrose is appropriate for correction of hypernatremia. Whereas if we use in first day of correction only N by 3 or N by 4, then it leads to rapid correction because the amount of free water increases in these fluids and isotonicity further decreases. So very well isotonic fluid is N by 2 with dextrose if we see according to free water content and isotonicity. But this is not holding true for severe hypernatremic dehydration where the sodium levels are more than 170. For that, the N by 2 fluid will be severely hypotonic. As I've mentioned, this chart was taken from Evries. Can share.
One more question, Dr. Neha. If we want to do a peritoneal dialysis in a baby of a refractory hypernatremia, any suggestions on how we shall customize our dialysate fluid for doing PD? If baby is in AKI with refractory hypernatremia, I mean, in spite of giving a lot of fluids, that hypernatremia is not getting settled down.
Most commonly, what fluid we use is 7.5% in PD fluid, but the customization according to the sugar levels and electrolyte levels, we can add it in the fluid only, MEQ per kg, but correct formula for sodium, I'm not very sure. We customize it for sugar level.
Okay.
Yeah. Other DM students?
Sir, for peritoneal dialysis, usually in neonates, we usually do not do peritoneal dialysis for hypernatremia, mostly in case of acute peritoneal dialysis done in case of acute hypernatremia. So, which is more commonly seen in bigger children who have excessive salt intake and salt poisoning.
I have a query, sir. Like in peritoneal dialysis, what we have done in our unit, sir, we have mainly used 2.5% 1.7 and 2.5% dextrose. Dr. Neha, are you like telling 7.5% dextrose is used in peritoneal dialysis because of the hypernatremia?
No. Mostly 2.5%. The customization which I know about it is sugar levels. Mostly 2.5% is being used. But for acute hypernatremia, we have not encountered a peritoneal dialysis. Maybe because of renal failure and uncontrolled hyperkalemia, maybe we are doing peritoneal dialysis.
Okay, thank you.
Hypernatremia, we are not.
And one more query, sir. Like we have seen one app for this, though I have not used this app. Is there any other like known apps which can help in the calculation for us on the bedside? And if it is available, can you share on the group? It will be helpful. Thank you.
Most commonly, which we use and I also use this is Neonate AI app. Apart from the calculators, this also have the charts and infographics also. And not only for hypernatremia, it calculates for both hyper, and other calculations also. This is a very
I think it has been a fascinating experience. Large number of you have participated, the fellows. May I have the words of wisdom coming from the faculty now?
Hello. A very good morning to everyone. I'm Dr. Anita from SGPGI. So, as far as hypernatremic dehydration is concerned, I would say whatever we know about it is mostly in the form of anecdotal cases which we manage. And it has been re-emphasized again and again that every case is different. So the calculations, lot of calculation we go through, and we should understand that a baby is just not that what we pour in and what is being coming out of the baby that would reflect in the form of plus or minus. So there are a lot of pathophysiology going on apart from the sodium dysnatremia and water balances. Baby may be in the sepsis, and other issues are there which can lead to fluid retention and intravascular extravascular volume shifts. So often what we feel that the formula is not working, the sodium correction goes not as per calculation. Sometimes it doesn't come as per what we aim for 0.5 MEQ per hour, or sometimes it drastically goes down. So most of the time there are additional factors which do affect the fall or rise of the sodium associated AKI, the urine output. So all these things has to be taken into consideration, and only answer lies and only solution lies in the fact that we have to be very vigilant monitoring and frequent assessment in the form of point of care sampling, and taking care of all every aspect of urine osmolarity, urine output, and renal parameters also. That is the thing, and I would say that we should compile our cases, that what happened in that particular case, what was that profile. So in that way, we would be better knowledgeable on the subject. Moreover, with the summer season, we see a lot of hypernatremic dehydration. So prevention is also very much important. So we have discussed this topic as a case, but it emphasizes that we should more frequently do weight monitoring, and especially in the babies who are near term or early term, and in the postnatal wards, and just look for the adequacy of breastfeeding, that sometimes baby must be not latching properly. So this is also a very important factor, that prevention should also be taken care in a better manner. Thank you.
Hello. Good morning, everyone. I think the points are well covered in today's session from both the sides, and there's no specific comment from my side.
Thank you, Kirti. Formally, good morning to all of you. It's one of the better mystery because of the more wider participation, but it would be a good idea that it's a complete participation. No one should be sitting without opening the mouth in mystery. That's the basic purpose, because we are all going through the examination, either a formal examination of the patient, the correct management of patient is an examination. So we all should be participating in this session. It is our own activity. So there should not be any inhibitions. And I should not be asking by name somebody. Take this as an opportunity. And every doubt is a relevant doubt. Whatever simple or odd it might look, but ask. Or give your remark if your experience, because then it will become a very versatile and meaningful activity. See, Dr. Anita just suggested that let's collate our series of cases. And then the experience would be tremendous. So I think Dr. Kirti or Dr. Anita, maybe or maybe people from this side as well, let's have collection of our cases, and then if we both the institute feel, then we can have a combined publication on case series, which will be very, very useful to the entire nutrition care providing fraternity. So this is my first remark. Now coming to the case management or some content input in particular. I think both units did a good job of presentation today. Shailendra as well as Neha, very good. Now, something which I thought should also have been talked about is osmolarity. Though I heard Dr. Anita mentioning it, but it did not become a part of our discussion when we discussed the topic. We have to, when there is a dehydration and hypernatremia, the sodium would definitely contribute on increasing the osmolarity, but there will be other components also which might increase osmolarity. For example, in our case, we had a urea which was very high, glucose was high, and if we do not take them into account, our management would be inadequate. Likewise, looking at the urinary osmolality simultaneously, which will give us a great amount of clue what's happening in the kidney has not been adequately addressed. So therefore, my suggestion would be that whenever you are dealing with the milieu of the blood with respect to biochemistry and hypernatremia, osmolality must be looked at and monitored with your treatment, that how they are doing, and treatment could be accordingly modified. So this is the first one. The second is that, as Anita again mentioned, that's a time for the weather is hot, there will be more cases of hypernatremia, which is true. And it was mentioned in one of the paper outside India. No, India is full of them. Publications are full of them. And therefore, we should be looking at prevention and early management. Early management, again, it's a gut line. Gut line should be most optimally used. Most of the calculation will be sorted out by gut. You don't have to do any calculation, but feed, feed, feed. And if you feed more effectively, maybe monitored, maybe supervised, your formula would be least required. Then I come to a problem where there is a moderate degree of hypernatremia. Well, n number of formulae have been discussed. We have made CPGs or NNF has written or IAP has written on hypernatremia and management. And always the remarks have been that there are too many formulae. Difficult to remember. If you refer also, then calculation problems. What I suggest that all formulae are good, but then you have to see that how much is the neonatal experience or your experience with those formula or formulae. I, for one, find simple things in life very good. And textbook of Robertson, he has written a very simple way of managing hypernatremia. Okay. And in my life, I practiced that. Even in Himalayan, we started doing it. It's very, very simple. Read it. I'm not giving the detail of it. If you don't get, then please, in next year, I will talk entirely about what is written. Very, very simple. Just one paragraph. Please follow that. The major point is that after you have started management, have a good follow-up. And see, normally we say, do not pick very early or do not pick very often. But once we are in an acute critical stage like this, maybe you do initially maybe hourly monitoring for some time of the serum electrolytes and osmolarity, and then make adjustment, make it 4 hourly. But certainly customize your treatment, adjust to whatever the body's need. You will never go wrong. So, simple formula, simple principles of management, and then close monitoring and modifying as per the results which are available. You will not fail. So I think this point needs emphasis, and we should practice and hope all of you should be reading Robertson. I don't say that you follow that, you have a choice, but maybe you may find it a wiser idea or a good idea for practice. Right.